Good afternoon, everyone. I'm glad everyone has gotten some lunch, and I want to welcome you to our forum on Medicaid for this luncheon session. We'll have our colleague Melissa Rogers, who will moderate this session. And briefly, Melissa Rogers is Distinguished Scholar in Residence in Faith, Law, and Public Policy at Wake Forest University School of Divinity. She also serves as non-resident senior fellow in the Governance Studies program at the Brookings Institution. Melissa is a nationally known expert on religion and American public life. She formerly served as special assistant to the president and executive director of the White House Office of Faith-Based and Neighborhood Partnerships for Presidents Barack Obama and Joe Biden. She also previously served as President Obama's inaugural advisory council on faith-based and neighborhood partnerships. She's the author of 2 well-received books. And without any further ado, I'm going to welcome Melissa Rogers to moderate our afternoon forum. Melissa.
Thank you. Thank you so much, Dean Walker, and thanks to all of you. It's great to be with you today. And I'm so looking forward to this important conversation and have enjoyed the proceedings that have come earlier today as well. As Dean Walker said, one of my jobs at the White House was to lead the White House Office of Faith-Based and Neighborhood Partnerships. And so I especially appreciate the role here of faith and community leaders who are working so hard to ensure that everyone has health care that they need, quality, affordable health care, and to demand environmental justice on behalf of everyone. So thank you to all the faith and community leaders who are here with us today. And thanks to you all, including, we have such a variety of sectors gathered here, from the faith, nonprofit, government, academic, health, and medical sectors. And it's just a really beautiful thing that I've been able to see at various parts of my career, where these sectors come together and reach out across their various sectors to help take care of people, especially those who are the most vulnerable. So thank you for all of your work, and thank you for the conversation today. I also want to say a special word of thanks to Dr. Hatch for his lifelong leadership on health and justice. You are such an inspiration to all of us, and we can't wait to hear from you this afternoon. In this segment of the program, we'll focus on Medicaid, including its past, present, and potential future. As our experts will explain in much more detail, Medicaid is the nation's public insurance program for people with low incomes, and it covers more than 70 million Americans. Medicaid was first enacted along with Medicare in 1965. Hubert Humphrey, who was President Lyndon B. Johnson's vice president when Medicaid was enacted, famously said, and I'm quoting here, "The moral test of government is how that government treats those who are in the dawn of life, the children, those who are in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped." Medicaid is aimed at passing that moral test. And these words, by the way, are inscribed on the walls of the building, the Hubert Humphrey building, that houses the Department of Health and Human Services in Washington, D.C., as a constant reminder to those who work there about their responsibilities. And we know that, put simply, Medicaid saves lives. And, we can just look at studies, and there are all kinds of them, but to just select one finding, studies have shown that childhood mortality is reduced for children who are on Medicaid. So that is just one simple indication of how important it is to have this discussion always, but particularly now when changes of a monumental nature have been introduced to Medicaid. So we know that this is important, and we know that the stakes are high. So while we'll discuss this issue as a matter of public policy, this is also a discussion of our collective morality, whether we will work hard together with government, doing all that we can to make sure that we take care of people who need this help so desperately. And it's not only just a public policy discussion, a discussion of collective morality, it's a discussion of practicality. As Dr. Bullard said this morning, it's about how we marry up facts with action to bring them to bear for people that needs help from government and from us. So we're going to talk a lot about how we help the people who depend on this important program, Medicaid. Healthcare is a fundamental right that is essential to human dignity, and so that is part of the stakes of our discussion today. So we're fortunate to have two Medicaid experts with us, one from the federal level and another from the great state of North Carolina. And that's very fitting because Medicaid, as you know, is a federal-state partnership. So both sets of government actors have a responsibility here. Let me briefly introduce both of our speakers. Jessica Schubel is my former White House colleague who served as special assistant to President Biden and Vice President Harris on healthcare and aging policies. Jessica helped craft and implement the legislative Medicaid and Affordable Care Act provisions that Congress enacted during this administration, as well as various regulatory reforms affecting these programs. Jessica also served in the Obama-Biden administration. She is the founder of Day One Strategies, whose mission is to help organizations navigate the complexities of healthcare policy and to craft policies that improve access to affordable, high-quality care for all Americans and to ensure that everyone can live and age with dignity. Jessica grew up in a small rural town in Western New York and graduated from Syracuse University and the George Washington University. And I'm so grateful that she's come down from Washington to be with us today. It's great to see her again. And next we'll hear from Dr. Larry Greenblatt, who is the State Health Director and Chief Medical Officer for the state of North Carolina. He's a distinguished physician, professor, and champion of public health. Dr. Greenblatt has served for 3 decades as a general internist, educator, and leader in Medicaid policy with Duke University Health System, earning recognition for his work to integrate behavioral health and addiction services into primary care. He has led Duke's Medicaid network, which serves over 100,000 Medicaid enrollees. Dr. Greenblatt has also served as chair of the North Carolina Medicaid Pharmacy and Therapeutics Committee and as secretary of the North Carolina Medicaid Physician Advisory Group. So we'll hear from both our experts with some opening remarks, and then we'll have discussion, including with you. So be thinking about the questions that you might have, and we'll really welcome those in just a minute after we do the opening remarks from both speakers. So thanks again for being here, and Jessica, over to you.
Oh, no, there we go. Okay. Thank you so much for having me and for the kind words, Melissa. I thought it might be good to start this afternoon just kind of going back to the basics, make sure we're all on the same page of what Medicaid is. So apologies for folks who are Medicaid wonks like myself and know all this, enjoy your lunch, have the cookie. But otherwise, I just kind of wanted to take a few minutes and just make sure we're, like I said, all operating from the same song sheet here. So the basics here, as Melissa said, it's the nation's largest public health insurance program for low-income individuals. In all states, Medicaid covers low-income kids, people with disabilities, seniors, and pregnant women, and some low-income parents as well. In 41 states, populations above what we call the Medicaid expansion population, that is low-income adults. They were often referred to as childless adults because they didn't meet the standard of the eligibility criteria for being a parent. 79 million people are covered by Medicaid, and that Medicaid accounts for $1 in $6 in the U.S. healthcare system. So we're talking big money, big influence in state budgets, which I'll get to in a second. And the Children's Health Insurance Program, or CHIP, works alongside Medicaid. I often describe it as it sits on top of Medicaid's shoulders, and it covers slightly higher income children, still relatively low income when you look at the eligibility levels. But it kind of, like I said, sits on top of Medicaid. So for purposes of this discussion, they're kind of all lumped in together. So in terms of how Medicaid is administered, as Melissa said, it's a joint federal-state partnership. The Centers for Medicare and Medicaid Services is the agency charged with overseeing it at the federal level. And it's, as I said, it's a joint partnership. The federal agency sets kind of the standards, the parameters that states can operate within, but there's a lot of flexibility that states have in setting up and designing their program, which I'll get to it in a second. So there's an old saying that when you've seen one Medicaid program, you've seen one Medicaid program. They all look different. They even use different names, and that's one of the things, we'll probably talk about later during the discussion is, I know here in North Carolina, it's called North Carolina Medicaid or NC Medicaid. In DC, where I'm based, it's just DC Medicaid. But in Arizona, where my family now lives, it's called Access. No one knows what Medicaid is. They're enrolled in Access. So we have language challenges. And I think part of the reason why a lot of folks in the public don't know or understand what's coming down the pike that we'll talk about with the HR 1 changes is because they hear Medicaid and they don't connect with it because it might have a different name in their state. So just again, briefly, Medicaid covers 1 in 5 people, disproportionately covers Black and Latino and American Indian and Alaskan Natives. That's the AIAN. It's a critical source of coverage for kids. Covers 4 in 10 kids, pays for 40% of all births. One thing, and I have a dedicated slide on this, Medicaid is the only health insurance program that pays for long-term care. So Medicare does not pay for long-term care. Only Medicaid does. So we have, it pays for 5 in 8 nursing home residents. And helps nearly 1 in 5 Medicare beneficiaries pay for their Medicare coverage, pays for their premiums. So what's covered? There's 2 kind of different benefit groups. There's the mandatory benefits, which is what you think hospital care, doctor's visits, nursing home, family planning services. Then there's optional benefits. Believe it or not, prescription drugs is an optional benefit that states can choose to cover or not. All states do, but it is one of those things that states can elect to do differently. Home care is another optional benefit. Physical therapy, occupational therapy, dental and vision care, all optional benefits. How is Medicaid financed? It's, again, because of it's a joint partnership between the feds and the state. Both kick in a specific percentage, and that split is based off of essentially how poor a state is, and the match rate differs across the country. So you'll see in the South, the match rate is quite high, but on the coast, like California and New York, they just split the cost 50-50 with the federal government. Different services and different people also get different financing matches. So, Medicaid expansion population gets 90% is covered by the federal government. States only have to kick in 10% of those costs. But some services also get 90%, like family planning services. So this is the complexity and wonder and beauty and frustration that is Medicaid. It's just very complicated. How much does Medicaid spend on and who? So as I mentioned, children are the largest group of enrollees in Medicaid, but states and the feds pay the least to cover them. Most of Medicaid financing goes to the elderly and people with disabilities. Medicaid, as I mentioned, is big business, big bucks for a state. It accounts for almost 30% of a state's spending in their budget. And 52% of all federal dollars coming into a state is usually Medicaid dollars. And just to put this in perspective, in fiscal year 2022, which I know is several years ago, but it's the most recent data we have. Medicaid has spent $804 billion on healthcare services, so it's a lot of money. As I mentioned, the Affordable Care Act expanded coverage to all adults. Unfortunately, the Supreme Court made it optional. And so that is why we have 11 states, the states in the green, that do not cover Medicaid expansion individuals. But North Carolina just recently expanded, so that's good here. It also made some other changes, modernized how eligibility is conducted, trying to make it easier for people to enroll through what we call no wrong door. Still a lot of work to do on that, but modest progress is still progress. And so, the ACA was one step forward. As I mentioned, when you've seen one Medicaid program, you've seen one Medicaid program. Some states do higher income eligibility levels for certain populations like pregnant women and kids, different benefit structures. Some cover some home care for one group, not others. There's a thing called Medicaid waivers or 1115 waivers. Those are also helpful in shaping and designing new policies to test within a state. So just a lot of variation across the board. As I mentioned, Medicaid is the primary payer for long-term care. Medicare does not cover long-term care. I just want to put that out there so everybody knows. Tell your parents that Medicare does not cover nursing home care or home care. So home care is optional, nursing care isn't. So there's an institutional bias that we have in Medicaid where people, if they go to a nursing home, will get Medicaid coverage. If they aren't and they need relying on family members to take care of them, that doesn't cut the mustard, so to speak. So hopefully we can fix that coming down the road. So just that's a little bit quick and dirty of Medicaid. Happy to answer any questions. I refuse to call HR 1 the other name for it, which is the big, beautiful bill. There's nothing beautiful about it. It's ugly. It's horrible. I can say this as a person of faith amongst folks here. It is morally reprehensible. It does not align with my values. I think the values here of being merciful, compassionate, and taking care of people, it does the opposite. The biggest thing here is work requirements. Most Medicaid individuals are already working. We know them. They're our neighbors. They're doing three different jobs. Your gig workers, your Uber drivers, your folks that work at the grocery store. But now they're going to have to prove that they are working at least 80 hours a month. There's certain exceptions to this. Parents with kids under 13 are exempt from having to fill out paperwork. People with mental illness or have a substance use problem, those are exempted from having to do this. But this is just a way to kick people off of their health care. Make no mistake, the Republican agenda here is to make it as hard as possible for people to get health care. We're seeing this with the ACA tax subsidies fight that's going on. In 15 days, people are going to experience significantly higher health insurance premiums if they buy their insurance off of the marketplace. So this is just part of their broader agenda of making it as hard as possible to get covered and stay covered. Another thing that they're making people do is every 6 months, they're going to have to go through another eligibility redetermination. So that means more paperwork for people to fill out. We have seen them restrict different immigrant eligibility groups, so they are no longer covered or eligible for Medicaid. It also, they made changes that will likely increase people's medical debt and increase their financial insecurity by taking away important consumer protections in the program. And it rescinds, rules that I worked on that try to make things better for people, and including setting, standards for how many nurses should be in a nursing home. So a lot of harmful things in this bill. A couple of other things that I'll just mention, they're charging copays for people to access care. We know that when people have copays, particularly when they are low income, they just won't go to the doctor. So it's another barrier to care. It makes some important financing changes that essentially puts more onus on states. It takes some tools out of state toolboxes to generate their share of the Medicaid financing. We call those provider taxes. So those are now, it's very wonky, but just know that it's just making it harder for states to pay for their residents' care. The other thing is this bill restricts states' ability to pay providers, specific providers like behavioral health providers, for example, more money to treat Medicaid enrollees. So that is being restricted as well. Just high level, cuts $1 trillion. This bill cuts $1 trillion from Medicaid and the ACA. That is the biggest cut to either of these programs in their history. Over 15 million people are going to lose their health insurance. That's 15 million people. As I mentioned, they're going to increase financial insecurity for folks, make it harder for people to enroll and keep their coverage. And nursing home residents won't have enough caregivers because of the rules that I put in place that are now rescinded. So in terms of where we're at right now in implementation, states are already working on how are they going to implement the work requirements, which take effect December 31st, 2026. Now, I know that's over a year away, but there's a lot that needs to go into system changes. And I will talk about this later, but there's a call to action for this group with faith leaders in particular of helping our neighbors make sure that they can get through all of the crazy red tape and paperwork now that they're going to have to do in order to keep their coverage. So, I often think that there's three words that I keep playing in my head as I'm talking to community organizations and how to communicate these changes is what do people need to do, when do they need to do it, and how do they need to do it. So that's the what, when, and how. I would keep that, in the back of your heads as we're having our discussion today about how we can help our neighbors keep their coverage. And I think that's it, but I didn't get the download on how to switch chair.
You just hand it off.
So.
What a terrific presentation. Thank you. Okay, let me try to get my slides up. This week was the 2-year anniversary of Medicaid expansion in North Carolina. It was December 1, 2023. And a figure I heard this morning was 687,000, but I think we're now over 700,000. My colleague, Deborah Farrington's here. She's nodding at me. Over 700, isn't that right? I think so, yeah. That's 100,000 more than what was anticipated. So a proud moment. That happened before I became a state government employee, but was delighted. So I'm going to touch on some of the specifics around North Carolina's Medicaid program, and I have some slides that overlap with Jessica, and I will go over those very briefly because you learned much of this. So in North Carolina, we have 3.1 million Medicaid recipients. This unreadable chart here tells you who they are, but it's roughly half children. We have a disproportionate number in rural communities. Can I share these slides? Can they be sent out?
Sure.
Okay,
Yeah.
I see folks taking pictures. I'm happy to share them. So it'll be better if you have the actual slides. And this figure here of 687 is now a little bit outdated. It is by far the biggest insurance program in North Carolina, and it is nationally as well. More people in Medicaid than Medicare. The changes you heard about, the federal changes in H.R. 1, this is specifically for people in the expansion program. People that are not in the expansion don't have this work requirement. And then in North Carolina, there's an expectation that it could be as many as 255,000 people lose their Medicaid, largely because of the challenges, the bureaucratic challenges of getting your paperwork or online or whatever, getting that done on time. In North Carolina, our Medicaid eligibility happens in our departments of social services, the DSS offices, and we have 100 of them. We have offices in every county. So to try to implement a substantial bureaucratic change that involves that many places and that many people, and by the way, they are underpaid, understaffed, they have lots of vacancies. It's immensely challenging. We are working on how can we automate the transfer of some of that information. If somebody has a job, can we get that data and just transfer that over so they don't have to come in with their paycheck stubs and the like. The bigger challenge is the people that meet the exceptions. Like, are they in school? Are they a caregiver for somebody with dementia? Do they have a young child at home? All of these things that are legitimate, but it is harder to capture all that. So many people will lose their insurance. The vast majority of those who do lose their benefit actually will meet one of the requirements, but they just didn't get their stuff done on time. Just to show you an example of this, so this is some data that I found in a publication. This is specifically about Arkansas, and then they have other states. And you can see in the age group 30 to 49 at the left side of the slide, the purple band are people that don't meet the Arkansas criteria for being able to stay on their Medicaid program. So that was, it's under 4%. The vast majority are either working, disabled, have some other qualifying criteria, whatever. So this tiny percentage actually don't meet it. So when you heard people in government talking about, well, if you're getting free insurance from your government, you should at least have a job. Well, almost everybody does, and that rate is comparable to what the general unemployment rate is. Like, people are between jobs or whatever, and you can see this is true in other age groups and in other states, and that number is typically 3 to 5% of people receiving Medicaid benefits in the expansion population won't actually meet these criteria. But again, is it a strategy just to be able to kick people off? So of the people who lost their insurance in Arkansas because of this system that they put in place, this is before HR 1, it was state specific, roughly 50% reported serious problems paying off their medical debt, 56% delayed care because of cost, and 64% delayed taking medications due to cost. The vast majority of people who lost their insurance were not able to replace it with, getting a job or getting some other insurance benefit. So they became uninsured, and that's likely to be what we see as well. The federal changes to Medicaid will impact North Carolina like all states. We anticipate losing almost $50 billion. That'll be over 10 years. Most of those will be cuts to the hospitals. That's where a lot of that money goes. Rural hospitals will see a somewhat disproportionate cut because they have more Medicaid recipients. They also have less financial resilience because of the fact that they're small, and they, with lower populations and a worse insurance mix, it's harder for them to stay financially solvent. It is possible that a trigger law could result in the end of Medicaid expansion in North Carolina, and that would be if the state's expense goes above a certain level. Currently, the 10% that's our share is paid for by hospitals. So the taxpayers of North Carolina don't pay anything directly towards the Medicaid expansion population through their state taxes. It's because it's 90% federal. And it looks like the hospitals will likely kick in some extra to pay for the cost of the recertification and the like. This is just showing you, then again, probably an unreadable slide from your seat. When are these HR 1 policies going to come into effect? The big one is these work requirements. It's going to start at the end of 2026. There's also work requirements being expanded for the SNAP benefit, which is the food benefit. The color coding in the bottom left tells you is it Medicaid, is it SNAP, and does it primarily impact rural communities? And I'm not going to go through that. It's a little bit much. The North Carolina General Assembly has not passed a budget this year. We are the only state that does not have a budget. And the governor asked for $819 million basically to continue the Medicaid program as it is. That's not to expand services or to do anything meaningfully different. It's basically to help it keep running. The money that was appropriated was $319 million short of that. So there was a lot of back and forth, and ultimately the Medicaid program, in order to essentially stay within budget, which we're obligated to do, had to cut payments to providers. So the cuts are going to be at least 3%. In some certain behavioral health programs, that might be as much as 8 or 10%. Nursing homes will get paid even less, and already they're pretty underpaid for Medicaid recipients. So there was a lot of unhappiness about that in the provider community, who already feel like, well, gee, it's hard for us to even come close to breaking even with our Medicaid recipients. And there has been some litigation specifically for providers in the autism community. And they won their case. And rather than, and they said that they were essentially being called out for it, like cuts above and beyond the 3%. And Deborah, just tell me if I'm getting this wrong. So the judge, instead of bringing them up to the 3% cut that everybody else got, said they'll get no cut. So, and where does that money come from? Unclear. And then are other provider groups now going to say, hey, if they're going to sue and win their money back, maybe we should get an attorney too. And so it's unclear what's going to happen, or where's the money going to come from. And we're hoping that the General Assembly will go back and fully fund Medicaid. I know the governor is encouraging that in our state. And that would be a place for advocacy for people in this room. If you wanted to know, what can I do to make sure that the Medicaid program stays robust and that providers don't drop out because their payments are being cut? Some providers haven't seen a pay increase in many years, and now we're cutting. Right, so inflation has gone up, particularly medical inflation. They're getting paid even less. But yeah, write to your legislators, call them, speak out on this. It's really unfair, and it hurts the most vulnerable in our state. So these are just kind of a summary slide of some of the things going on. In the blue are the federal actions, in the green are the state actions. So the federal cuts to provider taxes and state-directed payments. Then we have the state is cutting our reimbursements and some of our programs, more requirements. Medicaid expansion may be at risk too. We'll see about that. And then the appropriation. The technical term for that is the rebase. Our rebase came up $319 million short. In the past, when the General Assembly didn't fully fund Medicaid, there were lots of money coming from the federal government through the various COVID programs, and some of that money could be shifted into Medicaid, and then voila, everything was fine. Well, guess what? The COVID dollars, they're not there anymore, so that there is no way to make that up. So we're still struggling with that. I wanted to specifically mention a program that's separate from Medicaid, but it was created in response to the cuts to Medicaid. So I'll just spend a couple of minutes on this, and that is the Rural Health Transformation Program. And when I go out and speak to people, there's not, in general, a lot of knowledge about this. So some of you might be like, I know all about that. Well, other people might look at that and say, what is that? So this came out when HR 1 was being considered, and certain legislators didn't want to support it because of how it was going to hurt providers in their states, particularly rural providers and rural hospitals and the like. So you heard $1 trillion was cut, and then Congress added back $50 billion. So for those of you who aren't good with the math in your head, that's 5%. So we got 5% back to put into rural health initiatives to try to improve access to care, improve health, improve technology. $50 billion is a lot, but it's much, much less than was cut. So don't celebrate it too much. The half of that, this money will be given out over 5 years. So half of it basically was divided equally among all states. Think about the Senate. Every state gets their 2 senators. Every state gets their 1/50th of that $5 billion. So that works out to be $100 million per state each year. And then the other half, it was according to these 3 criteria: the rural characteristics, the proposed initiatives, and any policy commitments. Policy commitments were basically, was the state legislature willing to put forth laws that were in line with what CMS was wanting us to do? For example, in North Carolina, there was some pressure to allow nurse practitioners to practice without physician supervision. And that's, in our state, has been something that we don't allow. We want them to have a physician supervisor, but the federal government pushes that as a way to expand care. So the Sheps Center at the University of North Carolina, a nationally known organization, looked at some of the rural characteristics to try to predict how much would a state be expected to get. So, not every state will get the same amount on that second half, and North Carolina is predicted to get the eighth most money. Again, we have the second biggest rural population, but there are other things too. How big is your state? How many people live in very low density areas? Things like that. So in the end, we might get somewhere around $230 to $250 million. We're not sure. We'll find out by the end of this month. We're hoping. Deborah, who's sitting up front, she was our lead on our application. Tons and tons of work on that. A very strong application went in. These are some of the numbers around our Rural Health Transformation Program. It's about 3 million rural citizens. We have 6 initiatives. I'm not going to go through all that. We did have many, many stakeholders, literally hundreds, people that had suggestions and ideas and wanted to be involved in this. It's going to be somewhere, $200 million, let's say plus. A small rural population state likely to get significantly less. These were some of the major areas that we wanted to focus on for our needs assessment in the RHTP. A big one is access. Too few primary care, too few specialists, not enough nurses, direct care workers, you name it, not enough in rural communities, even when adjusted for the number in the population. Also long drives for people. Often you want to see a specialist, it might be 50 miles, 100 miles each way. People don't necessarily get time off from their jobs for medical, so they have to take a day without pay as well. So these are big challenges. There's a higher burden of chronic disease. There's more proportion of older adults there. Financial instability. You can see on the slide, there's quite a few issues that we were trying to address in our application. These were our 6 areas that we focused on. The dark gray bars above the colored columns are like where in the CMS notice of funding opportunity did these align. So we had to make sure our initiatives very much fell in line with the expectations of this. And so we really were trying to be very clear. We're going to try to bring in technology, including, some of you may be familiar with this, telehealth, where you can have a virtual visit with your provider. Also AI that can do transcription of the visit. You may have sat with a doctor where they have their phone going and poof, a note just appears. Okay, I'm a doctor, I retired at the end of May. What a great technology that is. And rural providers have higher volumes, and it's going to be a great asset. There's all kinds of information resources through AI that's going to make a difference there as well. We're going to try to enhance addiction care, mental health care, really care of chronic diseases, better cancer screening. There's a number of very specific things we want to do, though we want to let our rural communities really drive how these things will be done. They're the experts. We from Raleigh should not be going to our rural communities and telling them how to do this. We have to respect them and recognize that they've been practicing, they live in these communities, they know best how to get it done. So that's what I want to say, and thank you. And we're going to have a conversation. Appreciate your attention.
Thank you, Larry. Well, that was a lot, right? And so now we get to have a conversation about this very complex topic where the challenges are so serious. So because we started a little bit late, I want to make sure that we have plenty of time for your questions. So I'm going to turn to them just in a moment. I have a few questions, if you just wouldn't mind jotting down, and you can add them to the questions that come from the floor. But one of them is, there's a tremendous amount of myths that circulate about Medicaid and what it is. You've already hit at some of them, and the fact that most people that get Medicaid are actually working, as opposed to what is often said that is incorrect about that topic. So what are some other myths and facts that we should know and be aware of as we're discussing these issues in our communities to help educate people? And then in light of all these changes that are very sobering, to say the least, what are the most important things that policymakers can do at the federal and state level right now? What are the most important things citizens can do? Do we have any specific examples of advocacy that has made or is making a difference in this area that we can lift up for consideration? And what are some tips for all of us in engaging policymakers? You all are policy, or you used to serve as policymakers, so what would you advise people to do when they're asking for that meeting with their governor or their staffs or senators or representatives? And what are some good resources on these issues? So those are some of the things that I hope that we get to. Let me open it up now and just invite questions from the floor that Jessica and Larry can get to as they address those questions, among others. So just raise your hand or stand up as you wish. Okay, well, while you're getting your thoughts going, go ahead and bite on those questions then.
Yeah, I will leave the state policy making stuff to Larry. I will just say in terms of myths, I already addressed the biggest one, which is that Medicaid beneficiaries are sitting on their couch. I think that's what the conservatives like to say, is that's the young men playing their video games on the couch.
Getting a check.
And getting a check. In fact, some of my colleagues did some research earlier this year and found that really the population that is not working, who enrolled in Medicaid, are older women. Between 50 and 64-year-old women. It's not 22-year-old young men who are playing video games. It's older women who are taking care of their families, who might have a disability themselves. So this whole notion that people are lazy, that don't deserve health care, is completely false. The other biggest myth that I would say is this idea that undocumented immigrants are enrolled in Medicaid. Let me be clear, Medicaid does not pay for undocumented immigrants. They are not eligible for Medicaid coverage. So the idea that they're somehow receiving benefits is 100% false. What I will say is that Medicaid does help hospitals stay afloat and keep their doors open for the community by giving them money to pay for certain services that they provide on an emergency basis to low-income people, regardless of their immigration status. That's not coverage. It is merely to keep hospital doors open. So that is the second biggest myth that I think in Medicaid, is that somehow, the undocumented immigrants are being covered, and that's not right. Important things for policymakers, on the federal level, I try not to be too pessimistic about it, but I don't really know if there is no me sitting at the White House, staying lit up at night, worrying about how do I keep people covered. There is no Jessica there. In fact, the gentleman that is the new me, Theo Markle, is probably doing the opposite and thinking about what can I do to make it harder for people to stay covered. So I think if trying to engage with policymakers at the federal level, I think is more rooted in data, in facts. I think the career staff, the few that are remaining after the destruction of the government under this administration, is rooted in trying to do the right things, but having actual data, people's stories, is one way that I would recommend when you engage, at least on the federal level. I'll defer to my colleague here on the state. I think in terms of what we can do as citizens, I think not being silent is the biggest thing that we can do, and coming together as a community, particularly this community, in trying to help one another, our neighbors. I've been talking with my pastor in DC about how we can organize the churches in DC, and saying this, I will just say, preface this, it makes me angry that I have to think about these things, and having these words come out of my mouth just makes me want to throw up, but this is where we are, in trying to figure out how the churches in DC can get together to help people recognize that maybe when they help with the altar guild, that's volunteering, right? So maybe we can track, have the church track those hours and somehow give that information to the state to help their members keep their coverage. So I think, my call to action to this group is think creatively. My Oma, my German grandmother, would always say, God gave you a brain, so use it. So let's think creatively and think about how we can push the envelope to help people, to keep people covered, to just, not to be on my soapbox, I'm taking too much time, I'm sure, but this crazy idea that you can't have empathy and that is something, a weakness, is mind-boggling to me. And the idea that there are people in church saying that is even more disheartening. So I think not staying silent, being empathetic, and helping each other are the things that we can do collectively together as citizens to help people who are, they put their pants on just like we do every day, right? One leg at a time. And so I think we just need to all come together on that piece.
Thank you, Jessica. At some point, I need to go first. These are great comments. Thank you. Be thinking about your questions, please. So I'm going to just go through some of the topics that you pointed out, Melissa. So Medicaid myths. Okay, some of these are ugly. So I think a common one is Medicaid primarily serves urban people of color. So first of all, majority of Medicaid recipients in North Carolina are not people of color. There's a disproportionate number of people on Medicaid in the hardworking rural areas. They need Medicaid more than the urban areas do. Another is that providers lose money on Medicaid. Well, Medicaid doesn't pay as well as commercial insurance. In some ways, not all, it pays a little less well than Medicare, but it's way better than no insurance. And there were so many people using services because they needed them for their health where there was no reimbursement, where people were coming to EDs or primary care or community clinics or whatever. They didn't have any insurance and they essentially were free customers. And that's really hard for organizations to maintain their existence if some people aren't paying anything. So this is a big improvement for many, many areas. In some ways, Medicaid pays better. For example, if you talk to your pharmacist, how much you get paid for filling a Medicaid prescription versus, somebody that if you're on Express Scripts or Optum or one of those kind of programs, it's multiples. It's so much better, and it really helps float a lot of independent pharmacies, which are super important, particularly in our areas that have pharmacy deserts. So that's one example. There are others. Here's a myth that I think is one that's in favor of Medicaid, but it's wrong. So I heard this discussed earlier today, I won't say who said it, that in the end, giving Medicaid to people saves money. It doesn't. Giving Medicaid to people improves their health and their health outcomes. It allows them to go to work. It allows kids to be able to get vaccinated and the like. But in the end, it costs more than it saves. There are very few things in healthcare where you save more than you spend. Flu shots being an example, there aren't very many. But that doesn't mean we shouldn't allow people access to healthcare, right? We're the richest country in the world. That's crazy. Important things that policymakers or citizens like yourself can do, I would say absolutely speak up. Learn about these issues as you are today. Good for you for being here. Give yourself a pat on the back. Yeah. And then, organize. And, if there's like some kind of a rally or an event or writing a letter to the editor, but to not just quietly sit by when things are being taken away from people who perhaps are least able to advocate for themselves. People in Medicaid often work multiple jobs. They might have a lower level of education or literacy. They're not going to be like making an appointment with the state senator because they're not happy with their Medicaid program. They're going to be going to job number 3 so they can make sure that their light bill is paid and they can pay their rent. So sometimes others need to kind of step in and be that mouthpiece. Ways that you can advocate, certainly directly in North Carolina. People are here probably from other states too. Is that fair to say, or are we all North Carolinians here?
Pretty much North Carolinians.
Okay. But working directly with the state legislature, in our case, the North Carolina General Assembly, you can, if there's a gap in the coverage for Medicaid, you can actually advocate directly to the Medicaid program. If there is something that you think is missing, I have this condition or people in my community need this, they are open to hearing these kinds of things. And you heard about, like, for example, for the RHTP, we had, many people weighing in on that. And in general, the DHHS, the state government, we're interested in what people have to say. It's not just providers or policymakers that get a voice. Some things that you might say to a person when you are advocating, having more people have access to health care allows us to unburden emergency departments. I worked at Duke for many years. We used to have 8 to 14-hour waits just to be seen. And there were many people that were coming in over my many years there who just didn't have insurance. If they tried to go to a private practice, they would be asked to pay up front. They didn't have it. But if you go to the emergency department, they'll see you. So people end up having to go to the emergency department. So that's a way to get people to a place that's much more efficient. They're going to get better, more timely care. And others who actually have emergencies can be seen quicker. Having access to Medicaid allows people with chronic conditions or acute conditions to continue working. If you have bad asthma and you don't have any money for a doctor visit or insurance for your medicines, how are you going to go to work? You're going to miss a lot more work. Kids are going to miss school, et cetera. So if we want North Carolina to be an economically successful state, and we like to think we're the #1 state for business, and I think we are, but a healthy population has got to be part of that. Medicaid in general, and true in North Carolina, is the #1 payer for addiction care. So when people have addiction, it's very hard for them to function. They can't hold down jobs, they can't go to school, and getting people into care really makes a big difference and allows people for long-term recovery, and that helps to reduce crime. It keeps people working, and of course it reduces, the complications and the deaths related to overdoses and the like. When people are incarcerated, if they have access to Medicaid when they leave, they can get addiction care, which many people need, but they can get other chronic needs met, and they're much less likely to end up reincarcerated. So we're looking at increasing availability of the Medicaid program to people starting before their release from state prisons and also from our county jails. Resources, how do you learn more about this? The Medicaid has a lot of websites. I would say it is sometimes hard to find what you're looking for on the Medicaid websites. It's all there somewhere, but organized, maybe not the strong suit. Some good resources, North Carolina Health News, a website. I have no connection to any of these things I'm going to mention. I think they write really well. They cover the issues. KFF News, more from a national perspective. That's Kaiser Family Foundation. They've done some really, really good writing on many, many topics. And I would say our local papers, particularly I know the Charlotte Observer, the News and Observer, they cover Medicaid issues, I think, quite well and in quite a balanced way. So I think that's another place one can look, and they often online. Can we take a question?
Great.
Yeah, that's all I was going to say.
Thank you so much. Yes, please go. And let me summarize that question just for the sake of the video. Thank you very much. So the question is about the Medicaid redetermination systems that often have a lot of man-made barriers, such as only being open from 8 to 5 when people are working from 8 to 5, so they can't access the system. And how much flexibility will the state of North Carolina have to deal with these problems and overcome them potentially?
That's a great question, and I'm going to invite you to serve on the panel if you'd like to have this seat here. You're clearly well informed. No, seriously, a great question. And I think you're right that there are a lot of bureaucratic hurdles that are built into the system. Certainly there are people in DHHS, and it's not me, who are working really hard to how do we make this process as frictionless as possible for people who meet the criteria, who are working, who don't have the time, or maybe don't have a computer with a broadband, and they are going to rely on the DSS workers to get this stuff in for them. People started the second this came out, people really, that week, the meetings began. We don't have all the details yet from the federal government. So we can't know exactly what flexibility we have, but we're going to try to make it as easy as possible. I think we at the state government level, we want to see as few people lose their insurance benefits and their SNAP benefits as possible. So, and thank you for laying out some of the hurdles that we're likely to encounter.
I'll just add two things, and I saw your hand. So on a federal, so a couple years ago, after the pandemic ended, during the pandemic, everyone who was enrolled in Medicaid got continuous coverage, and we went through this thing called Medicaid unwinding, and that is literally something that kept me up at night for 10 months straight. Is how do
Jessica,
I
can you say a little more about what that is? Yeah.
Oh, Medicaid unwinding? Sure. So when the pandemic started, there was a rule that Congress put in place that states could get extra money, but in order to get that extra money, you couldn't disenroll anyone until the public health emergency was declared over. So starting in March of 2023, we started this process of redetermining everybody's eligibility. So people who had had continuous coverage for 3 years were, for the first time in 3 years, having to reapply essentially and having a look at to make sure that they were still eligible for Medicaid coverage. And that was just in the Biden administration, we wanted to make sure people had health insurance during the pandemic. It seemed like common sense, right? So that process was a 12-month-ish process. Every state had to undergo it, and every Medicaid beneficiary had their eligibility checked again. Now, I wanted to make sure this was going to be as painless as possible. It was still really painful. Going back, I would have done some things differently, but I really charged CMS with making sure that they could help states with electronic information, being as flexible as possible, not having to require so much paperwork. If someone, they did a eligibility, like a data check with electronic data, and it came back, with a $0, but someone said, oh, I don't have any income. I'm filling out a form and saying I self-attested. Okay, fine. Let's rely on what came on the electronic data. So just being as flexible as possible. I will say the one good thing about HR 1 is that now there is a requirement on states to do as much as they can electronically. So there's, in theory, supposed to not rely on so much paperwork. So there's new thinking about new data sources to try and help people, not have to put in so much paperwork, to your point about it goes into some black box. But the reality is, there's fewer people to process the paperwork. There are, really old systems. Some of these systems are older than I am, and I'm 43. And there's issues with that. There's issues of people just not, as Larry was saying, having the equipment, broadband to upload. There's all kinds of things, right? One of, I think, a really great story, great in a terrible sense, with this is that there's a story about this gentleman, Adrian McGonigal from Arkansas. And when Arkansas put their work requirements in place, he worked at a chicken processing plant. He was like, okay, I'm going to fill out the paperwork and I'll put in my hours. He didn't realize he had to do it monthly. He thought it was one and done. So he had asthma or COPD, some type of condition that required an inhaler. So he goes to the pharmacy to pick up his inhaler, and the pharmacist tells him, sorry, but this is no longer, you don't have insurance, this is no longer covered. Not only could he not get the care that he needed, because he couldn't control his asthma, he lost his job at the chicken processing plant because he couldn't be around, feathers and chicken without going into an asthma attack. So this is the problem that the challenge that we're all collectively going to face, is making sure people understand it's not just one and done. That you're going to have to continually follow these reporting requirements and navigate all the hurdles that you mentioned.
That's great. And can you, while we're on this topic of work requirements, which loom so large, what would you recommend to people who really care about people getting health care and being in group settings, houses of worship and the like? I mean, does it make sense to think about doing tutorials on work requirements and helping people understand what is step by step what they have to do in a particular state? And Larry, how much flexibility does North Carolina have in interpreting these requirements as sensibly as one could?
We don't fully have all the federal requirements spelled out yet. So one thing that I should have said earlier that's notable is that many companies are interested in trying to help with this process. So for example, to create apps. And we don't know, is it going to be okay for an individual to self-attest, yes, I'm a full-time student, or I'm caring for my aunt who lives with me who has dementia, or some other way that they are meeting the requirements. If people can self-attest and do it on an app, that might make this a whole lot easier. So maybe a way to be helpful is to just help people to download and install and use an app. Like sometimes people need a little help with that to get started. And if you have that skill set, and many people don't, that might be a great way to do it. And certainly to like remind people, it's got to be every 6 months. Now, if it's an app, it can alert you on your phone, like you have 3 weeks to get your paperwork in, or you might lose your Medicaid benefit. That might be a way to do it. But again, we don't have the full picture yet. But capitalism waiting to jump in and make that process easier. Hopefully that could all then be sent directly to DSS, and then that makes the job of the DSS workers, who now have to do twice as many eligibility recertifications each year for that population, make it easier for them. A friend of mine does this kind of like app teaching. There's a food pantry in my community. They have huge numbers of people growing rapidly, and that used to be like you had to wait on a very long line, literally hours. People would have to wait every 4 days or so to get a food box. And they said, let's go with an app system, and they quickly realized all the elders got excluded from getting food, and they were just it unintentionally biased the system against people who are less technological. So I have a friend who's good at this stuff. He's a retiree. He's out there teaching older people how to install the app, use the app, and make sure that they're still able to eat, because people are like dependent. It's going to be much worse for this, right? It'll be more complex.
I would even take 10 steps back. I was at a conference with Medicaid directors, and the Michigan Medicaid director said they have done focus groups, and the Medicaid enrollees in Michigan do not know what a work requirement is. That is what we're up against. And in Michigan, they were on the precipice of actually implementing a work requirement during the first Trump administration. So to answer Melissa's question about what we can do, this is, yes, a tutorial. There's a thing, I don't know, it's like the slide deck parties, I guess, is a thing, or presentation PowerPoint parties or something I've heard. I think this is actually a good idea that I just came up with. Why don't we have after service for fellowship hour, we put a PowerPoint, party for fellowship, or we do a young adult thing on, a Thursday night. Or, we have a knitting, with older adults. I don't know, coming up with some type of event where we bring people together to community organizations, community centers, churches, wherever, so we can bring and do 101 stuff. I mean, this is very basic. Like, it goes back to what I said in my slides, is the what, when, and how. We need to keep those three things in the back of our mind of what do people need to do, when do they need to do it, and how do they need to do it. So I think I think the app stuff is, to the extent that is available, but I think we need to do like basic 101 information. But I know you had a question,
Melba?
so I
Yeah,
wanted to
please.
make sure you had time.
Yeah.
So I'll let Larry talk about it on the North Carolina piece, but I'll say two answers to that. Going back to what I said, no, I don't think people understand. I think we need to do 101. But to the broader, head scratching question of why do people who actually use Medicaid vote for people that take it away from them, I don't have the answer. It kind of flummoxed me. I remember going to an event right before President Obama left office, and there was a woman who was talking about how the ACA had saved her life, and she was enrolled in Medicaid. She was in Kentucky, but she voted for Donald Trump. And I thought to myself, wow, he's going to take your health care away, and he made no bones about that at the first time, but she still voted for him. So I don't know how to square that circle, quite frankly. But to Larry's point, there are a lot of, I'll just come out and say, there are a lot of poor white people who are enrolled in Medicaid who are going to lose their coverage. The only reason why those 11 states, which are congregated in the South, that have yet to expand Medicaid is because it's a racist thing, right? They don't want Black and brown people to have health insurance. So they're willing to sacrifice everybody just for that. That's my 2 cents.
Let's see. I see one hand up here. Yes, please go ahead.
Immigration piece, I'm not an expert, so, it can help you find the right people. I mean, between Melissa and I, there's lots of our colleagues that can help you there. On the data sharing, I think that it is an issue. I think this goes back to what some of the folks on the other panel talked about, which is trust. And I think, for communities, particularly, Latino and other immigrant communities, is making sure that community leaders have the right information. But like I said, Melissa and I can help direct you to the status questions, because I'm just a health policy person.
Yeah.
Sorry
Yeah.
for the answer.
Happy to follow up with you after this. And I think we have to bring it to a close. But I want to say that first I want to thank, and I hope you'll join me in thanking our expert panelists, have been so helpful. And also to say that I know this is a lot that has been presented and a lot that's really disturbing. I think what we'll do moving forward, this is one beginning of a conversation. I hope that we can continue this conversation and think about what we can do practically to share models that will help people understand what's coming and how to prepare themselves, and how we can help people in the gaps as well, that fall through the gaps. I know this is a big topic, and I just want to say that we'll keep working on this. This is not a one and done conversation, because it is so incredibly important to our nation and to people in need. So thank you again for what you do. Thank you for being here today and for participating in this conversation. And we very much welcome your ideas for us. And I'll share my contact information, make sure it gets to you, because this is an issue that's close to our hearts, and we want to work with you to make things better. Thank you so much.